Welcome back. All right, let's just jump right into a clinical puzzle that I'm sure we've all faced. You've got a patient who can barely stand up, they're so unstable, but you run your peripheral vestibular tests and they're completely normal. So what's going on? Well, to figure that out, we have to go deep into the vestibular output pathways that go beyond the eyes, the absolutely critical circuits that control our posture and our very sense of what's up and what's down.
So let's set the stage for this whole discussion, which is based on the fantastic Anatomy of Vestibular System review. We're going to dive right into that puzzling clinical scenario. So picture this. You've got a patient with just profound postural instability. I mean, they can't stand. But then you do a VHIT, a video head impulse test, and it's totally normal. What is going on here? Well, that paradox, that's our clue. It's screaming at us that we're not looking at a problem in the inner ear. We're looking at a central problem. And today, we're going to give you the anatomical map to pinpoint exactly where that lesion is with confidence. To crack this case, you have to think of the vestibular signals as hitting a fork in the road right after they leave the vestibular nuclei. One path goes down the spinal cord. That's for posture. It controls all our anti-gravity muscles. The other path goes up to the cortex. That's for perception, building our conscious idea of where we are in space. Two totally separate routes. Okay, section 1. The descending postural tracts. This is basically our anti-gravity system. So let's start by following those downward pathways that stop us from just collapsing into a heap on the floor.
So take a look at this. It lays out the two major players in our vestibulospinal system so clearly. In blue, you've got the lateral vestibulospinal tract, the LVST. Think of this as the heavy lifter, the absolute powerhouse for our anti-gravity extensor muscles. And then in red, you have the medial vestibulospinal tract, or MVST. This one's more of a specialist, really just focused on keeping your head and neck stable.
And this table just nails the key differences. So the LVST, it starts in a place called Dieter's nucleus, the lateral vestibular nucleus. And this is super important. It doesn't cross over. It's ipsilateral, running straight down the same side of the spinal cord, firing up those extensor muscles. Now, compare that to the MVST. It starts in the medial nucleus, it's a bilateral system, and it's pretty much just focused on the neck and upper back to manage the vestibulocolic reflex. Okay, so why does all that matter? Here's the clinical payoff. Because that LVST is an uncrossed ipsilateral pathway, right? If you have a lesion in the lateral medulla, a classic Wallenberg syndrome from a pica infarct, you knock out the origin of that tract. So what happens? You lose that anti-gravity push on the same side as the lesion, and boom, the patient falls toward the side of the infarct. It's beautiful, isn't it? The anatomy literally gives you the diagnosis.
All right, let's switch gears. We've gone down, now let's go up. The ascending cortical pathways, and how we actually build our conscious sense of what's vertical.
Now this is where things get really, really cool. You know how vision and hearing have their own dedicated VIP relay stations in the thalamus? Well, the vestibular system doesn't play that game. It's more of a team player. Its information gets spread out across these little thalamic islands, like the ventral posterior inferior and ventral posterior lateral. And these aren't just vestibular hubs. They're mixing pots, integrating our sense of balance with touch, with body position, with motor planning before any of it even gets to the cortex.
So, where does all that integrated information end up? It converges on this one key spot, buried deep in the brain, called the parieto-insular vestibular cortex, or PIV. Now, it's not the only spot, but you can think of it as the main headquarters for our conscious sense of motion and where we are in space. And check this out, this is a huge clinical pearl. For most of us, especially right-handers, it's the right hemisphere that does the heavy lifting for processing all this spatial info. And what does that mean in the clinic? It means that a stroke on the right side is often way more devastating for a patient's sense of space. You'll see these really dramatic tilts of their subjective visual vertical, much more so than with a similar lesion on the left. It's a key localizing sign.
All right, time to put it all together. Let's talk about localizing central syndromes, taking this anatomy and putting it to work in the clinic. Let's solve that puzzle we started with.
And this just lays it out perfectly. Look at the difference here. A tiny little hit to the posterolateral thalamus, smack dab in those vestibular relay islands, and you get something called thalamic astasia. We're talking a profound, pure inability to sit or stand with falls away from the lesion. They just can't stay upright. Now, take that lesion and move it higher up into the cortex. What do you get? It's more of a perceptual problem. The patient feels tilted, their whole world is skewed, but the postural failure might not be nearly as catastrophic.
And this quote, this is the answer.
This is the answer to our question from the very beginning. That patient who can't stand but has a perfectly normal V-hit, you need to be thinking about the thalamus. A tiny lesion there can basically pull the plug on the brain's internal reference frame for gravity, and that's why they collapse. Even though the peripheral VO arcs we're testing with the head impulse are totally fine. They're separate circuits.
Okay, let's wrap up with the key takeaways. The big picture stuff you absolutely need to remember for clinical localization.
All right, here are the 3 big ones to take home. Number 1, Dieter's nucleus or the LVST gets hit, the patient falls towards the lesion. Simple as that. Number 2, you see that profound postural collapse, but the rest of the neuroexam looks clean, you gotta suspect a thalamic lesion causing thalamic astasia. And number 3, big perceptual tilts, major spatial disorientation, look to the right hemisphere. That right hemisphere dominance is key.
So, we've covered a lot of ground, haven't we? From the spinal cord all the way up to conscious thought. But we're not done yet. Join me for our final explainer where we get into vestibulo-autonomic integration. We're going to map out the pathways that explain everything from motion sickness to how we can localize complex syndromes like Wallenberg, all the way to an AICA infarction. You will not want to miss it. As always, thank you so much for listening. If you want to dive deeper into dizziness, vertigo, imbalance, or find some great resources for you or your patients, head over to AustralianDizzinessClinics.com. And of course, if you found this helpful, please subscribe and leave a rating. It really helps a lot.